And if I invite to the stage Janna, who's going to tell you about the work that they do in women's health. So Janna, over to you.
Thank you. Well, good afternoon. It's really an honor to be here with you. And my name is Janna Guinen. I want to first thank the European Connected Health Alliance Global Healthcare Connector Partnership and also ECS for organizing this UNGA Science Summit event, and also to Cure for hosting us in this beautiful space. I'm here to talk about women in health, the health of women around the world, and global opportunities for women in healthcare and medicine. I'm not a researcher, a physician, or a technologist. I'm here today as an advocate. I'm the executive director of the Health Foundation, a private charity to advance health equity, diversity, equity, and inclusion and well-being in the healthcare workforce. This mission encompasses gender minorities and women, as well as the needs of other underrepresented health populations. The Health Foundation is lucky to have proximity to Health Inc., the healthcare events company that hosts 3 annual events, Health US coming up shortly, which draws 10,000 healthcare professionals to focus on digital health innovation. And on behalf of the Health Inc. team, we can't wait to welcome you in a little more than a week from now in Las Vegas. Starting next June, we'll host the first Health Europe event in Amsterdam, and the third of these events is VIVE, co-hosted by Health Inc. and CHIME, the College of Health Information Management Executives. And this event covers digital health implementation and the business of healthcare. The Health and VIVE events provide Health Foundation with a platform for sharing information and convening an increasingly global audience around our mission. Our Women's Impact Program is one important way that we're advancing our gender goals, together with programs also focused on patient empowerment and health equity. The Women's Impact Program brings together a content agenda where leaders present on challenges and progress in gender equitable health and significant networking opportunities as well for women, allies, and gender minorities. Our affinity meetups gather attendees affiliated and identified with a group underrepresented in healthcare, and also provide visibility to nonprofit partners supporting these groups. We also design activities to engage and inform our attendees around key issues, such as our patient consultation service at Health. This benefits female and other patients and caregivers by offering their expertise to industry professionals responsible for designing and implementing digital health products, health plans, direct patient care programs, and more. But today I'm going to focus on the Health Foundation's mentorship program. I'll get back to that in just a moment. But this is the Science Summit. I want to talk for a few minutes about science at a high level and how, from my vantage point, it can achieve even more. We owe so much to science, as we've heard from the other presenters. The scientific method is, in my opinion, perhaps the most influential and productive system of thought ever devised. Medical science has influenced the most profoundly positive changes in human life. A little more than 100 years ago, communicable disease was the leading cause of death around the world. Diagnostics, vaccines, and therapies have literally changed the course of life. Global life expectancy today is more than twice as long as it was in 1900, and the possibilities seem limitless. In the next era of medical science, we will develop exponentially faster and more complex knowledge, standards of care, and technology-enabled healthcare interventions. But as an advocate, I must point out, with progress in medical and healthcare implementation science and the social sciences, we already have the information and technology to resolve many of the poor health outcomes experienced by women. And yet, we have not. Globally, women's relatively poor health compared to men is in large part due to inequalities that lead to poor healthcare access, lack of agency, higher poverty, lower participation in the economy, and lack of educational opportunity. For example, despite government investment in universal care, a woman in India is less likely to have health insurance than a man. She may not be allowed to make choices about her own doctors or her care. She is less likely to own a mobile phone or have internet access than her male counterparts, most especially if she lives in a rural area or comes from a household with a lower income. Worldwide, 800 women die daily from preventable causes related to pregnancy or childbirth, and more than half of these occur in Africa. An adolescent girl growing up on the continent of Africa is 3 times more likely to be infected with HIV compared to boys her same age. As a woman, she will do the lion's share of unpaid caregiving. This facet of women's lives contributes to lost income opportunities and higher and more severe poverty among women. And of course, poverty is well understood as a contributing factor of poor health. And these challenges are not limited to low and middle income countries. In Europe, women also have decreased access to healthcare during their lives compared to men, especially single mothers, older women, and those living in poverty. This applies across the board to physical, behavioral, and dental care. Here in the United States, women have a longer life expectancy than men, but often experience worse outcomes. They are diagnosed later than men for more than 700 diseases and are more likely to suffer from chronic pain. Speaking globally once again, according to one 2022 study, regardless of where they reside, a healthy old age is untenable for far too many women due to 3 primary factors: the prevalence of chronic health conditions, financial insecurity, and abuse and violence. All of these are mediated in part by societal inequities. Until recently, medical data was still by and large based on studies of men. So we are living with a big gap in information about women's biology and health and disease, their clinical symptoms, and their response to therapeutics. And of course, there are conditions and experiences also that are exclusive to females. In the United States, we now have the highest rates of maternal mortality of any other high-income country, and it's more than 10 times some nations. Black women in the US are greater than 3 times more likely to die in childbirth than white women. For American Indian and Alaska Native women, the rate of death is 2 times higher than for white women. And women of color in the United States are much more likely to experience the death of their newborn. I'm going to go on just for a moment more on this. Floods, droughts, and other natural disasters kill more women than men and kill them at a younger age. And looking to the future, studies now predict women are more likely to be casualties of extreme weather due to climate change. What now? In the face of these statistics, this knowledge, I believe science must embrace a new approach. And this brings us back to the Health Foundation's mentorship program called C-Sweetener. This is a year-round program that gives women and non-binary healthcare professionals a year-long mentorship for free. C-Sweetener's goal is simple: one by one, to increase the number of women and non-binary people, including those with intersectional identities, in the uppermost tier of healthcare leadership. Right now, we have more than 200 mentors in this program, people of all genders from every area of healthcare, each of them bringing at least 20 years of experience and volunteering their time to help our members advance in their careers. C-Sweetener has provided over 650 mentorships so far. That's thousands of hours of mentoring sessions to learn from. Mentees come into the program at a mid-level in their careers, when women are most likely to drop out of the workforce. This is an ideal time for mentorship. Positive changes in her career can make important differences in a woman's economic security and therefore her health. In general, mentorship is shown to improve job satisfaction and pay, retention, and lead to accelerated promotion. But there's more. Here's what I've observed. Rather than prescribing a solution, the best mentors ask open-ended questions. Listen. They allow the mentee to openly share their point of view and bring ideas to the table as an equal participant in problem solving. Good mentorships are built on the full representation of both parties. Top mentors are inclusive, opening their networks, making connections to find solutions. They ask, who is missing from this conversation? And they actively seek out thought partners and connections for their mentees. And mentors know that participation matters. They are taking responsibility to do something about the leadership disparity in healthcare and medicine. They demonstrate the value of caring for others, taking action on inequity, and becoming real champions for their mentees. In a good mentorship, progress is personal to both parties. And when these elements are present, full representation, inclusion, and caring, we see that mentees become better leaders. They receive promotions and recognition at work. Some make career changes or take on a new role where they can give back as volunteers. Mentors say they continually learn from mentees. They feel rewarded, and frequently, lifelong relationships are formed. So in its own small way, C-Sweetener is helping to change the face of healthcare leadership and helping to secure women's health and well-being. The impact of this program is why we are now starting the process of making C-Sweetener available to more people outside the United States. In scientific terms, mentorship is qualitative, and that's its power. Healthcare has ever more sophisticated engineering, sensors that can detect minute changes in health status. We have molecular diagnostics and imaging, advanced clinical trials to establish an evidence basis for new pharmaceutical therapeutics and digital interventions. Data storage solutions, computing ability beyond anything we've ever known, and a wonderful, exciting new capacity for accelerated learning in all fields with generative AI. However, progress toward equity in health and medicine will require that in all practices of science, we adopt some of the attributes and values demonstrated by the best mentors. Representation, careful, deliberate effort to seek out those missing from our data collection, our computations, boardrooms, innovations, policymaking. Inclusivity, the willingness to be curious, to ask and listen. Caring. Actually, what is caring but a form of positive bias? Let's get comfortable with this form of bias. We need caring, focused attention to combat gender inequities in health, because good science can never eliminate caring's opposing force, discrimination. Discrimination is the root cause of many health outcomes disparities, but we can do much better in accounting for this negative bias in designing studies, policies, care delivery, and technology innovations so that everyone benefits. What does this mean in practical terms? It means committing to hiring and advancing a workforce that reflects the diversity of patients, designing studies, care delivery, digital health tools for cultural and language concordance, health and technology literacy, and mobility. The endeavor of ensuring health technology is ready and able and accessible to mitigate health equity, or TEQuity, is another initiative we are working on at the Health Foundation. I'm happy to say we have healthcare industry partners in this effort, but we need more. We need everyone. As a health equity advocate who is thoroughly enamored with science, I hope that we can make room for science to be more like mentorship. Let's adopt representation, inclusivity, and caring as a framework and a committed ethos for practicing science. I'm confident that if we can be like the best mentors, we can make great strides in achieving health equity for women and all people living with unjust barriers to good health. Thank you.